Welcome to this special Gastro Girl podcast. This episode was produced in collaboration with the American College of Gastroenterology's Patient Care Committee. Here's your host, Jacqueline Gaulin.
Hello, everyone. Thank you for joining us today on this episode. We are joined by Dr. Christopher Velez at the Center for Neurointestinal Health, Division of Gastroenterology in the Department of Medicine at Mass General Hospital and Harvard Medical School. He's the lead author of a very insightful and important review article published in the American Journal of Gastroenterology called Digestive Health in Sexual and Gender Minority Populations, also called SGM populations. Now, this review summarized the effects of social determinants of health and discrimination on healthcare access. It also highlights the important digestive diseases to consider in the SGM population and offers solutions to improve and prioritize the health of these communities. And I'm really excited and honored to have you, Dr. Velez, on the show today. So thank you so much.
Thank you so much for having me. I love to have the opportunity to chat more about this.
Yeah, so I read your article and it was very in-depth and very eye-opening. And I hope today we can kind of, from a high level, just give our listeners who are predominantly patients, but we have a lot of providers that listen in, on really the highlights of what you've done here. And, if you could just highlight, what was the purpose of your research?
So excited to describe that a little bit more. I think first off, particularly at the higher level, thinking about terminology. So you'll see that as you referenced, we used a term, my colleagues and I used the term sexual and gender minority, or SGM. Really, that's the same as LGBTQIA. So lesbian, gay, bisexual, transgender, queer, intersex, asexual, and others. It's meant to be a more clinical term, in part also reflecting that what is challenging from a research perspective is that oftentimes the terminology that's used can vary over time. So for example, the Q part of LGBTQIA is the word queer, which historically has been used as a slur and has been adopted by members of these communities as sort of a badge of honor, if you will, or a identity marker that reclaims what can still be a slur, and depending on whoever's using the word. So SGM and LGBTQIA, just for a perspective of terminology, I may filter in and out of using the terminology based on that. So now that we have a little bit of vocabulary, clear it up, I think that what we are noticing over the first years of the 2020s is increased effort on trying to think about health inequity, why people in the wealthiest country on the planet don't have as good outcomes within the US, or why in terms of industrialized nations, why the United States often has worse health outcomes compared to our peer-rich nations. And part of what's thought to drive health inequity are social determinants of health that are usually unfairly sorted around the populations. They tend to impact more racial and ethnic minorities, so immigrant groups, Black people, Latinos like me. It can also influence, most likely, the health inequities that most likely exist among LGBTQ people. We haven't studied them, in part because it's hard to get a sense of what would constitute a good patient cohort, in part because there are many aspects of LGBTQ identity that remain marginalized, or unfortunately in some jurisdictions are being actively legislated against. So that's going to probably cause some people to retreat. That has to be associated with poor health outcomes, which likely include poor GI gut health outcomes. So the point of the article was to give a sort of a lay of the land of what's known in the early 2020s about digestive health needs, areas for research, in the LGBTQIA communities, sort of a call to arms for patients to be aware that this is something that their providers should become increasingly aware of, but also hopefully for patients to have the confidence that there are people like me, like my colleagues, like Dr. Paul and Sonali Paul and others, she's at the University of Chicago, that we are trying to address what is likely a community that is at risk for adverse health outcomes.
No, thank you for the overview. So one of the things that you outlined at the beginning was the effects of social determinants of health and discrimination on access. So could you kind of give an overview of what they are and what patients in that group are experiencing?
I actually just came from teaching a class at the medical school today. And one of the units that we taught this course was looking at colon cancer screening, for example. When someone has to go for a colonoscopy, they have to have insurance to make sure that it's covered. They have to be able to afford the medication to clean out their bowels. They have to be able to pay for the medication to clean out their bowels. They have to be able to take off the day from work in order to have the procedure done. They need to be able to find someone who can accompany them. They need to be able to find someone who can then take them home. They need to be able to review results when necessary with the doctor who performed the procedure. When we were in the throes of the pandemic, you had to get COVID testing done prior to your elective procedures. Any of those steps for people who don't speak English as a first language, who are underinsured or not insured. We're lucky in Massachusetts that we approach near universal rates of insurance, but it's not 100%. Someone who can't afford the medication, someone who knows someone who doesn't know anyone, let's say someone who's elderly or someone who's in a more rural environment, doesn't know anyone who can accompany them to a visit or no one that could accompany them home, or they're an hourly worker and a day off from work means that they've lost wages for the day. This is a good explanation for different social determinants of health that change the result and outcome, which is, let's say, poor colonoscopy rates. Now let's think about it from the LGBTQ perspective. We have in some jurisdictions now legislation that is attempting to make the ability of providers to refuse care to LGBTQIA legal from the perspective of conscientious objection, which I think is unconscionable. But
oh my God, no, that's terrible.
And you have people that are used to being mistreated by society, not that they should be used to it, but that they are, and they're afraid, perhaps in the setting of sexual violence, which is high in the LGBTQIA communities, particularly transgender individuals, transgender women of color in particular. And a colonoscopy can reassert those traumas. So these are the things that I think about when I think about social determinants of health that likely impact adverse health outcomes among the LGBTQIA peoples. And that's why we need to study it. It hasn't been studied routinely or in systematic fashion. And that's what I'm hoping collaborators and I can do in the coming years to better understand the needs.
Now, in your paper, you did a really great chart, a flow chart, where you showed the life stressors, biopsychosocial factors, and how that, ultimately could lead to various GI diseases and disorders, and ultimately some morbidity and reduced quality of life. Can you walk us through, some of these life stressors and things, especially that are very predominant in this SGM population of patients?
Yeah, that's a great question. A little difficult one to answer, in part because so much of this is not known. But let's start off early in life, when one is an adolescent or still dependent on parents or parental figures or loved ones to care for you. If you become homeless in the setting of an adolescent, and a large portion of youth homelessness does impact LGBTQIA populations, that may mean that you can't complete schooling. That may mean that you have to resort to commercial sex work in order to be able to feed yourself or to get a roof over your head. You then incur the risk of adverse health because you can't eat well. You may not get enough calories, or your calories may be heavily processed, or you may end up having a sexually transmitted infection in the setting of commercial sex work just because of the way that industry goes. You then miss out on economic opportunities in order to get that good insurance to be able to have a full day off and also benefits in order to be able to have a full day off to undergo a colonoscopy for colon cancer screening. Those decisions that are made to cope with the biopsychosocial stressors in life that are more prevalent in LGBTQI populations, it's that cumulatively over days, weeks, months, years, decades, that undoubtedly shaves off the life expectancy of LGBTQIA peoples and results in worse health and poorer quality of life. What frustrates me about some aspects of research that's done to address the likely inequitable health outcomes that exist in digestive health and LGBTQIA people is that it has been riddled with implicit bias that suggest that it's behaviors such as promiscuity or tropes that exist against LGBTQIA peoples that is what explains their predilection to certain disease prevalences or incidences, if you will. We need to do a better job as a profession to understand that it's these upstream elements of the biopsychosocial model that then result in disease outcomes that we see as physicians. Unfortunately, I'm sort of at the end of the line, if you will, of all those biopsychosocial stressors that result in disease. So one has hepatitis infection from intravenous drug use, or has contracted HIV, or suffers from obese body habitus, and then has resulting impacts on liver function. The horses have left the barn. What we need to do as a society is addressing these biopsychosocial stressors. And unfortunately, the past year, I would say we've gone backwards in terms of identifying their stressors. And now the things have become perilously worse for LGBTQIA populations in half the country. And that's sad to see as a physician, because I know that's going to end up resulting in different disease inequity starting now, but also for the next 10, 20 years of my career.
Yeah, that's a really good point. There's just, especially in our current climate where it's at the forefront of discussion and debate and animosity amongst a lot of people who don't understand the differences and the unique challenges faced by this community of people. For patients, I always try to take the approach of the patient. To understand what are some of the digestive diseases that they should know about, that they could be at maybe greater risk, or they should, and you mentioned some of the things, embarrassment with colonoscopy because of past traumas. How do we reach patients in this population to educate them and help them, and to help them feel supported?
Fantastic question. I think that it's hard, and I think it depends on what the local environment is. Things aren't perfect in Massachusetts, but I know that I can be comfortably out as a gay gastroenterologist without any professional repercussion. And if patients sort away from me or towards me for that purpose, it is what it is. But I can authentically live my full life in a state like Massachusetts. In other parts of the country, that may not be, but LGBTQ people are in every state, in every city, probably in every county, in every country, in every society on the planet. So there are going to be people who have needs that are living in a jurisdiction where there is an increased desire to criminalize aspects of LGBTQ life. That makes that local environment more challenging. So I think that what providers should do is, what physicians should do is first recognize that the person in front of you who needs your help, period. Without wading into larger socioeconomic considerations as it relates to the need for universal healthcare, I would say that the person sitting in front of you, it shouldn't matter what they've done in their life. You should not to equate someone being LGBTQ status as someone who has committed a horrendous crime, but I should not treat someone who has done something horrendous any differently than someone who has not done something horrendous, but may have a quote unquote different belief system or different way of living. I shouldn't have to be mentioning that in the 2020s, but I think that is what we have to first start off with. Beyond that, it's outreach, it's partnering with national organizations, advocacy organizations. There are gay and lesbian physician organizations. There's GLAAD, there's having a health outreach at the community level, just to let LGBTQ people know, no matter where they live, that people are interested in making sure that they have as best health outcomes as they can. Those are the small steps that are more important while we try to stabilize things and while we try to improve the access that likely isn't as equitable among LGBTQ people, particularly those of intersectional identity, such as LGBTQ people who are from racial ethnic minority communities or rural communities or immigrant communities, where they can have that additional burden added on as well. So really it starts off locally and having a healthcare system that is affirming of LGBTQIA people's identity and lack of need to ask for others to exist. Once you have that foundation, the rest comes from there.
No, that's great. What about for patients and patients that may be listening to this and may identify with what we're talking about? What do you recommend for them? How do they approach a healthcare provider if they have access, obviously? And how do they feel comfortable talking about their health needs and what they're experiencing, some symptoms and things like that?
It's another fantastic question, and it's so individual. It can be difficult to make a broader recommendation, but I think that their word of mouth is important for understanding which providers provide affirming care and which ones don't provide LGBTQIA affirming care. What I mean by that is doctors who are known to be respectful of LGBTQIA people's identities and are less likely to commit implicit bias. I always assume that I can commit implicit bias, so I think anyone can. I think going back to a point that we were talking about before we started the podcast proper, that I make mistakes. And I think that if you can find a doctor who's willing to say I make mistakes sometimes, you're already halfway there. I think that when it comes to being transgender, given the increasingly targeted attacks against the transgender communities, that's tough. What I would say is when you engage in pronoun discussions, being cognizant of the need sometimes to repeat what you would like to be called. It should, hopefully the person on the other end of that conversation, the doctor on the other end of the conversation, won't be flustered or won't be upset. I've definitely made mistakes. I've misgendered people. I've called people not by the name that they would prefer to be called by, and I welcome being corrected. So I would hope that that's what someone listening, a patient listening in, would feel comfortable doing. I think that it's finding that doctor that is able to have an open, honest conversation of what your life is like, what you can do to reduce harm, what you can do to lean on sources of support, be they a friend, a close friend, a partner, trying to engage a doctor who recognizes that network, because it doesn't all need to be doom and gloom. There's a lot that's good in the LGBTQA communities. And there are sources of strength among the communities. Leaning on those communities, both formally through advocacy organizations or through local networks, I think is a way to get the health that one needs. I seek out care in places where I know that they typically see people who are under the LGBTQA communities. That's not universal, but they exist regionally. So leaning into regional and national resources, I think, can help someone who's LGBTQA identifying navigate and get the care that they need.
Yeah, and that's something that we tell all patients. If you're not satisfied with the care you're getting and you're speaking up and you're still not getting what you need, you have every right to find a new healthcare provider that you feel more comfortable with. And it's like a partnership. So you want to make sure that you feel comfortable to share your experiences and not feel embarrassed and feel heard and listened to. So across all patient populations, I think that's key. Wouldn't you agree?
I agree. It's what I feel privileged to be a physician, but at the end of the day, this is my job. Your health is your 24/7, 365 life. So I may not always see eye to eye with patients, but I always approach the perspective that if I see someone a few times a year, at most I see them over an hour and a half and 2 hours of their year. They have a whole other 24 times 7 times 365 that they're going to be outside of my office. So I'd rather use shared decision making to get to a mutually agreed upon conclusion versus dictate what someone should or should not do. And I think everyone should have that right. I think the main theme is its biopsychosocial stressors likely lead to inequitable health outcomes in digestive health and LGBTQIA people. That's why I care as a gastroenterologist to study this more. And I think that gut symptoms are very common. So for anyone listening and they're having gut symptoms, it's very stigmatized, particularly when it comes to bowels, talking about one's health. I think that there is sometimes people falsely reassure patients when it's not a dangerous diagnosis like cancer, for example, that, oh, you should be fine. There are options to help you feel better in terms of your gut. So the next time you're at a physical, or if you're thinking about speaking with someone about something that's troubling your gut or your tummy, I would encourage you to do it because there are lots of good treatments that exist out there.
And lots of great resources. We have great resources on GI OnDEMAND, ACG, GI.org, Gastro Girl, and a lot of it addresses the brain gut interaction, which can be helpful for every patient who's suffering from different stressors and it's affecting their digestive health.
Yep. And that's actually when I'm not advocating for trying to better understand health outcomes in LGBTQIA people, that my bread and butter are disorders of gut-brain interaction.
Oh, okay. So, that's right. Neuro. Yeah. You're a neuro. Yeah. That's so cool. I love it. If
there's one disease that's definitely a whole body disease, are those disorders like irritable bowel syndrome that unfortunately some doctors will dismiss as being problematic, but can be pretty, at times, traumatizing, particularly if associated with accidents or things like that. But at a minimum, could definitely impact quality of life. So,
right. And there's associations with trauma and other things, PTSD, sexual trauma that affect your IBS. So it's not something unique. You don't have to feel embarrassed about it. We have lots of channels for care, as Dr. Velez said as well. So I'm so grateful for your insight. This is a very important topic. It's a tough topic. There's a lot of factors, and maybe we can revisit and break different areas down in our efforts to be collaborative and to really help, shrink the disparities that exist. And if we could do our part by providing education that's more attuned to the needs, we're happy to do that. Just let us know.
Absolutely.
Okay. Well, thank you so much.
Thank you.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.